Assalamu alaikum. Dr. Asad, can you hear me? Should we start now or should we wait for 1 or 2 minutes?
I think we should start. Let's start.
Okay. Okay. Assalamu alaikum. I would like to welcome you all to yet another tele-echo session of 2021 from our series of on hepatitis echo. I am Kiran Amir. If I haven't met you before, I am the administrator of Parsa Echo Pakistan and given a new role uh, recently as Super Hub lead. I am the co-facilitator along with our director, Dr. Asad Ali Chaudhry. Let me introduce our expert panel for today's case-based discussion. Dr. Asad and Dr. Oj will present 2 cases today. To discuss them in detail, we have with us Professor Altaf Alam, our course director and consultant gastroenterologist and hepatologist, Evercare Hospital, Lahore, and Dr. Zeeshan Ali Junejo, our project lead SIN and associate professor of medicine, JSMU and JPMC, Karachi. Few standard announcements before we start the session. We are part of a global movement called Project ECHO based in New Mexico, USA. Our objective is to disseminate best practices and knowledge. By default, you are all muted to maintain discipline during the presentation, but we do encourage participation. So you can always unmute yourself, introduce yourself and ask any question or use the raised hand option or chat box. We do protect patient privacy, so none of the information shared today will identify any patient or individual. For CME credits, please contact Mr. Ozair, our coordinator. So I will hand over to Dr. Asad Ali Chaudhry for the case.
Thank you. Thank you very much, Kiran. Bismillahir Rahmanir Rahim. We start with the case, and it's a pleasure to have Professor Altaf and Professor Zeeshan with us. Our first case is an interesting one. So I will be, we just come across this case yesterday, and we would like to hear from the expert. So let me share my screen. Okay. I hope you all can see this. So this is a 63-year-old gentleman. Is a known case of ischemic heart disease and had angiography and stenting done in 2015. He had double vessel disease at that time. He's not a known diabetic. He's non-smoker and non-alcoholic. Last year in May, he was diagnosed having multiple myeloma. It was confirmed on serum protein electrophoresis, and he had bone marrow biopsy at that time. And he also had renal failure at that time. So he had chemotherapy, and he was also started on hemodialysis at that time. He did well, but in June 2020, he had a fracture right neck of femur, and he had surgery done, which he tolerated, and at present he is mobile. He presents to our clinic last week with acute hepatitis. He's developed jaundice. It was a painless jaundice, a little anorexia, and hepatitis B and C were both positive. On examination, is a conscious, oriented, soft abdomen, liver is palpable 1 to 2 fingers. His family history was not significant. And if you can see here, in May 2020, when he had multiple myeloma, his viral serology is negative and HIV is negative. And on 8th of February, you can see hemoglobin 11.5, platelets are good. His creatinine is 5.3. He is on twice daily hemodialysis session. Bilirubin 4.8. ALT is 676. AST is 1048. Alkaline phosphatase is 672. Gamma GT is 1560 and albumin 4.3. Anti-HCV is reactive and hepatitis B surface antigen is reactive this time. And on 14th of February, bilirubin is slightly risen, but ALT, AST have come down a little bit. So is alkaline phosphatase and minimal reduction in gamma GT. Albumin still looks good. And you can see very high viral load of hepatitis C and hepatitis B. The ultrasound shows mild coarse liver. So he is doing well at the moment, and the oncologist wanted to start lenalidomide as maintenance for multiple myeloma. So the question to experts are, what further investigations are needed? Does he need urgent antiviral treatment as he awaits start of lenalidomide as maintenance for multiple myeloma? And if we treat him, so which will be the which virus needs to be treated first? So I leave this on here, and I would request Professor Altaf Alam Saab to open the discussion here. Ji, Dr. Saab.
Thank you very much. Asad, can you hear me?
Yes, we can hear you.
Okay. Very typical. In Pakistan, the hemodialysis units don't practice good infectious control policies. They do not get the viruses from the machine. They get it from bad practices within the unit. So it's sad, and certainly calls for improving infectious control policies within the hemodialysis unit. So here we have a gentleman, 63 years old, who has ischemic heart disease, underwent stenting, develops multiple myeloma and renal failure, has had chemotherapy, and now on hemodialysis. Surgical treatment for fracture right neck of femur. Typical presentation with acute hepatitis, and on investigations, HBsAg, anti-HCV, HCV-RNA, and HBV DNA by PCR are all positive. So ultrasound shows a coarse liver. The infection seems to be short because he was put on hemodialysis not long ago. So the infection is not very old. But remember that in renal failure, the changes in liver develop rather early. So ultrasound shows coarse liver, which does not mean anything. We need more information. And certainly, if you go for the first question, what further investigations are needed? So in the blood workup, I would certainly like to have an INR in a patient with liver disease, particularly acute hepatitis. In context of multiple myeloma, I certainly would like to have a calcium level here, which is missing, calcium phosphate, LDH, uric acid, so which are missing here. With any patient with hepatitis B, Delta virus check is mandatory. So anti-HDV test should be done. EPRI and FIB4 are not applicable in acute hepatitis, so don't try and apply them here. I would certainly, again, with acute inflammation, fibroscan is also not very useful. So you have to keep this in mind, that these investigations have their limitations. But certainly, this seems like a new infection, recently acquired, as they call it. In the latest guidelines on hepatitis C by EASL, they have omitted the term acute hepatitis C and they call it recently acquired hepatitis C. And certainly he seems to have acute hepatitis B as well. So in terms of further investigation, some blood tests would be helpful here. And that's all I have to say in terms of investigations. EPRI and FIB4 cannot be applied here. This is acute hepatitis. Fibroscan, with the presence of acute inflammation, which happens in acute hepatitis, is not very reliable. So these things are not going to help.
Thank you. हमने sir इसमें as you have said, I'm sure we keep up this patient and we'll follow up in our subsequent discussion. Apart from what you have mentioned, we also have sent hepatitis B core IgM along with Delta you mentioned, and I've also sent A and E IgM just to, I don't know whether I was being it's like it's over investigation, but what are your comments? I mean,
no, I would certainly welcome that, because how can you say that A and E is not the cause of acute hepatitis? So certainly I would welcome that, and that is helpful.
Okay, Dr. Zeeshan, Professor Altaf has summarized the whole case, and we have discussed investigation. Would like to have your comments on investigations, if you have any more to add. And going on to second question about need of urgent antiviral treatment in this case. Ji Zeeshan.
Assalamu alaikum to all, and I would just agree to what Professor Altaf has said. And very important learning point here is in acute hepatitis or in any inflamed, significantly inflamed liver. Because I would like to share the data which we collected here at JPMC, in which we found that any ALT above 150 is falsely over predicting when we are comparing the elastography. So they are over predicting the fibrosis when the ALT is more than 150. So forget about the acute hepatitis. Even in chronic hepatitis patients where the ALT is very high, the fibroscan values would be over predicting, and these EPRI and FIB4 are not at all applicable to acute hepatitis. And that was just a comment in the data sharing, which we did a study with biopsy series of 50 patients of biopsy here at JPMC. Now, coming to the urgent need of antiviral therapy, there are two aspects. One is multiple myeloma, other is chronic renal disease and hemodialysis patient. These are two immunocompromised states, and he is waiting for a maintenance therapy for the multiple myeloma as well. So one is his overall disease condition, which makes the case of antiviral therapy, so that his liver damage may be exaggerated. So we should plan for antiviral therapy. The other thing which we look for all patients in absence of these comorbid condition is acute and chronic liver failure or impending acute liver failure, which we discussed previously as well in the previous session, that the INR is very important here, and the ultrasound does not show any ascites in this patient. But if the INR is more than 1.5, then it becomes the case of impending liver failure, and that determines the urgency of the treatment, antiviral therapy. But here in this case, his overall medical condition warrants the treatment, and we should plan the treatment. But before going through it, we should get the blood workup done. Yes, sir.
Thank you. Dr. Altaf, you have any comments here before we move on to question number 3, which is which virus will need preferential treatment?
Right. I totally agree with what Zeeshan has mentioned. This patient is immunosuppressed. And the third element is lenalidomide. This is a similar drug to thalidomide, and I have come across 2 recent patients, so I know what it means. There is data in literature to suggest that, like rituximab and other immunosuppressants, lenalidomide also leads to hepatitis B activation, but has no effect on hepatitis C. So there is a problem with this drug and hepatitis B. So hemodialysis, multiple myeloma, and the drug therapy, all these warrant urgent antiviral treatment, at least for B. C, we never considered it as an emergency in the past, but the recent EASL guidelines, which have recently been, a couple of weeks ago, they have released that, and they have changed the term acute hepatitis C to recently acquired acute hepatitis C, and they have mentioned treatment without waiting. But, it is up to you or me to wait for hepatitis C, because multiple myeloma, chronic renal failure and dialysis, as well as the therapy that is planned, has no effect on hepatitis C. So in terms of B, I would certainly immediately start treatment for hepatitis B. Now the question comes, what treatment? Ideally, this gentleman is 63 and has had fracture, so he must be having osteoporosis or bone disease, or myeloma involving the bones. Ideally, he should be given tenofovir alafenamide. Now, what are the contraindication of tenofovir alafenamide? It cannot be given if the creatinine clearance is less than 15 and the patient is not on hemodialysis. But if the patient goes on hemodialysis, it is now approved for use in hepatitis B. So this patient is already on hemodialysis, and he can be started on tenofovir alafenamide after each session of dialysis. Dose remains the same, 25 milligram. If this drug is not available, which is not a problem in Pakistan, you can use any other drug once weekly, entecavir or tenofovir disoproxil fumarate, in the normal doses once a week only. So 1 tablet once a week. But for tenofovir alafenamide, 1 tablet 25 milligram after each session of hemodialysis. And as Dr. Asad said, he gets hemodialysis twice weekly. So he gets 2 doses of tenofovir alafenamide, available by different names. Dose is 25 milligram, and you use it twice weekly. So I would certainly start him on hepatitis B treatment, which to me would be tenofovir alafenamide twice weekly after each session of dialysis. For hepatitis C, somebody who starts treatment now, he's doing fine. If he wants to wait for 2 weeks, 4 weeks, 6 weeks for bilirubin to come down, that is also fine. It's not going to do any harm. But if you follow the guidelines, immediate treatment is warranted, because in that case, you only give 8 weeks treatment, either GP, which is not available in Pakistan, glicapravir and pibrentasvir, or you use Sofwell or Sofdecla. Sofwell to be given for 8 weeks, but if you are using Sofdecla, it is to be given for 12 weeks. There is no interaction of either of these drugs, Sofwell, GP, or Sofdecla, with the proposed treatment for multiple myeloma. So that should be all right. And now in CKD, on hemodialysis, you can use the same doses of treatment, standard drugs, 8 weeks treatment as recommended by recent EASL guidelines. Thank you.
Thank you. Thank you, sir. Zeeshan, you have anything to add on these comments?
I don't think so. Professor Altaf has already summarized the case very elegantly, and the main guidelines has been discussed, and uh, treatment of Hep C remains your and mine call, though the current guidelines do suggest with this immunocompromised state to start with, but you may defer it, and I agree with that. It's up to you, but the dosage and the drug regimens have already been discussed. We should move on to the next case now.
Thank you. Zeeshan, just one thing is, in this acute hepatitis setting, hepatitis C का follow up तो relatively simple है. How would you like to follow up on hepatitis B? और आपके क्या concerns होंगे जब आप उसको follow कर रहे होंगे? We start him on tenofovir alafenamide, and there was a question of on alafenamide, okay, what is the reason to give TAF after dialysis session? Is that it is rapidly removed by dialysis, or is there some other reason? So you can answer uska follow up, or what is the reason for TAF after dialysis? Ji Zeeshan.
First thing, follow up. जैसे कि हमने बात की है कि we are looking for potentially acute on chronic liver failure or acute liver failure, impending acute liver failure. So if that is the setting we are starting with, क्योंकि अभी हमारे पास INR नहीं है, तो we exactly don't know what would be the setting. If we are dealing with acute liver failure, definitely the different ball game, and we would be following this patient to begin with 48 to 72 hours LFTs and INR, and then weekly for 4 weeks, depending upon what the response of the patient would be. And the acute liver failure has to be managed by tertiary care setup or the advanced liver setups. If it is acute hepatitis B with no evidence of liver failure, then still with this very high bilirubin and the ALT, I would be following weekly at least LFTs and INR in this patient. And the PCR may be repeated at 8 weeks or 12 weeks interval, but the LFTs and the INR has to be followed weekly till it becomes normal. And then in every 12 weeks, we will be following with the PCR and LFTs once they are settled. So I hope that answers the follow-up of hepatitis B in this case. Now, coming to the question which was in the chat, after the dialysis, most of the drugs have got uncertain blood levels after the hemodialysis. So if they have got renal clearance, as this issue with the renal adjustment of the dose, we give it after the dialysis is standard procedure, and this drug does get washed out by the hemodialysis. So it has to be given after the dialysis, not before.
We are now open to questions on this case. If somebody has a comment or a question, आपके पास raise hand option है, or you can unmute and join the conversation.
There is a question in the chat. I can see probably the additional precautions for the bone with TAF. TAF generally itself doesn't, it is recommended for the patients who have got some risk factors for the osteoporosis. And this particular gentleman is suffering from multiple myeloma. His problem is the multiple myeloma and the metabolic bone disease, which he is suffering from. TAF generally is safe and does not have effect of demineralization of the bone. So we don't have to worry about it. It is safe for the patients with a bone disease.
Okay, thank you. So if there are no comments or questions, we move on to the next case. Dr. Oj will be presenting the next case. George?
Nadeem Tehami is here. Does he want to make any comment on this case number 1, if he has seen the case. Nadeem, please.
Sir, बहुत शुक्रिया. I actually joined a bit late, so I missed most of the discussions, but I look forward to the case number 2. Thank you for the opportunity.
Dr. Oj, please go ahead, start.
Ji, sir. Can you see the screen?
We
Okay.
can.
Ji, sir. This case is a 35-year-old male weighing 100 kg. BMI is 30.2. Known case of chronic hepatitis B since 2005. No history of AVT and presented in OPD with complaint of heat intolerance and urticaria. No comorbidities. He is a non-smoker and non-alcoholic. And on examination, abdomen is soft, non-tender, and chest is bilaterally clear. Family history is mother and sister are HBs antigen positive and no history of HCC. The investigations, as you can see, in 2019, his HB is 15.5, TLC 12.2, and platelets 185. In 2021, his TLC is decreased, but otherwise CBC is normal. And CRET is 0.92. And in 2019 and 2021, the LFTs are more or less the same. AFP in 2021 is 2. HBe antigen is non-reactive, and anti-HBe is reactive. Anti-HTV and anti-HIV are negative, and anti-HCV is also negative. And his HPV DNA was detected in 2019, but it's 20 international units per ml. And in 2021, they're slightly increased 153 international units per ml. And his fibroscan, which was done in 2019, was F3, F4 Metavis score. Median stiffness is 11.1 kilopascal. And ultrasound abdomen, which was done in 2019, grade 1 fatty liver. No ascites or splenomegaly, and no SOL in liver. The questions are, what further investigations are required in this patient? And should we start AVT in this patient? Thank you.
Thank you, Oj. Let me just summarize this case. The young man, 35 years, BMI is 30, and known hepatitis B since 2005. Non-smoker, non-alcoholic, and if you can see in family history, his mother and sister, they are surface antigen positive. But there's no history of HCC as told by the patient. In investigations, ALT is high in 2019 and 2021. It's more than double. E antigen is negative, E antibody is positive. Surface antigen quantification was done in January 2021, and that quantity was 31,000. And DNA is less than 200. In 2019 is about 20 units, and in 2021, this month, recently it was 153. Fibroscan is 11 kilopascals. Fatty liver on ultrasound. And now what to do with him? Should we start him on treatment? The first question is actually, do we need any further investigations in this case? Dr. Altaf, another interesting one. Gujranwala mein to hum dekhte hain.
Very good. Yes, certainly very interesting. Obese gentleman, 35 only, B surface antigen positive, low viral load, but very high quantitative surface antigen, E antigen negative. Alpha feto is normal. 2 years ago, and ultrasound and fibroscan are contradictory. Fibroscan F3, F4, and ultrasound just showing fatty liver. So there is some contradiction. Obviously, he needs certain investigations. आपने हिस्ट्री में बताया कि हीट इंटॉलरेंस है, अर्टिकेरिया है. तो पहले तो डर्मेटोलॉजी कंसल्ट. आई एम नॉट वेरी गुड इन स्किन डिजीजेस. हीट इंटॉलरेंस के लिए थायराइड फंक्शन टेस्ट हम जरूर करेंगे. नंबर्स पूरे करने के लिए हमें सोडियम INR की जरूरत होगी ताकि हम इसे क्लासिफाई कर सकें इनटू स्कोर्स. और नया अल्ट्रासाउंड और फाइब्रोस्कैन, आपने अल्फा फीटो तो रीसेंट दे दिया, लेकिन रीसेंट फाइब्रोस्कैन और अल्ट्रासाउंड हमें चाहिए होगा ताकि हम ये देख सकें कि वेयर वी स्टैंड। एप्री और अगर कैलकुलेट करें तो सर्टेनली ज्यादा है। नाउ क्वेश्चन ये अराइज होता है कि ये सब कुछ हेपेटाइटिस बी कर रहा है या नहीं। सो नॉट वेरी सिंपल क्वेश्चन टू आंसर। हेपेटाइटिस बी कर भी सकता है क्योंकि ये ट्रू इनएक्टिव कैरियर नहीं है। वो मैं कैसे कह रहा हूं? ट्रू इनएक्टिव कैरियर का सरफेस एंटीजन क्वांटिटेटिव लेस देन 1000 होना चाहिए। सो ये ट्रू इनएक्टिव कैरियर नहीं है। और अगर हम बाकी तमाम लिवर डिजीजेस को रूल आउट कर दें, जो कि इसमें मेटाबॉलिक, नैश, तो हम ये कह सकते हैं कि यह हेपेटाइटिस बी की वजह से है। सो इस पेशेंट पे इन्वेस्टिगेशंस में सोडियम चाहिए, आईएनआर चाहिए, अल्ट्रासाउंड चाहिए, फाइब्रोस्कैन चाहिए, अदर कॉजेज ऑफ लिवर डिजीज चाहिए हमें, फेरेटिन, आयरन, टीआईबीसी, ताकि ट्रांसफरेंस सैचुरेशन कैलकुलेट कर सकें और हीमोक्रोमेटोसिस की सस्पिशन को साइड पे कर दें। विल्सन्स इज हाईली अनलाइकली इन दिस एज ग्रुप, सो उसको आप ओमिट कर सकते हैं। ऑटो इम्यून लिवर डिजीज को जरूर देखें। थायराइड, मैंने पहले बोला, थायराइड टेस्ट को जरूर देखें। और ये इस बात को इग्नोर ना करें कि ये साउथ ईस्ट एशियन और इसका बीएमआई 30 से ज्यादा है, जबकि साउथ ईस्ट एशिया में ओबेसिटी की डेफिनेशन इज बीएमआई मोर देन 25 एंड मोर देन 30 इज मॉर्बिडली ओबीज। सो इट इज अनलाइक कॉकेशियंस जहां पर 30 पे ओबेसिटी शुरू होती है और 35 to 40 आप मॉर्बिडली ओबीज कहते हैं। सो ये मॉर्बिडली ओबीज है। और यहां पर अ केस कैन बी मेड टू डू अ लिवर बायोप्सी। आपने बता तो दिया कि अल्कोहल नहीं लेता, लेकिन हु नोज, प्लस क्योंकि नैश स्ट्रॉन्ग पॉसिबिलिटी है, इसलिए उसके लिए ये लिवर बायोप्सी ही आपका मसला हल करेगी। फाइब्रोस्कैन आपका, ऑफ कोर्स अल्ट्रासाउंड ये तो होंगे ही, और लेकिन आई वुड सजेस्ट कि ये इन्वेस्टिगेशंस। थैंक यू।
Thank you very much, Dr. Altaf. It's very interesting case. मैं वैसे इसकी लिवर बायोप्सी पे भी थोड़ा सा कंफ्यूज होऊंगा कि किस को मैं कितनी वेटेज दूं। अगर फाइब्रोसिस आ जाता है और वो फैटी लिवर की तरफ जाता है तो फिर भी हमें क्वांटिफिकेशन को, और डीएनए is detectable anyway, though in low quantities. So it's a very difficult situation sometimes. So anyhow, Zeeshan, for your comments and the $1,000,000 question, are you starting him on treatment?
Again, it's an interesting case, and I would agree that there is a disparity between the surface antigen quantification and HBV DNA. Learning point again, the HBV DNA itself is not always the predictor of the viral replication, and the surface antigen at times give you a better view of viral replication. So we know that this virus is replicating with high surface antigen levels. But the question is it due to B? That remains to be answered. And I would go for the biopsy in this particular case to answer the how much component is fatty and how much component is B. Yes, we would like to see other causes of the hepatitis, chronic hepatitis excluded, as Professor Altaf mentioned. But looking into the patient's profile, it's very likely to be NASH overlapping with hepatitis B. It may be both of the disease taking the toll on the liver at the same time. And in investigation, I would like to look for lipid profile and HbA1c as well in this particular case, Again, these are the typical phenotypic patients which presents with diabetes, and when we screen them with this fatty liver and this obesity, they turn out to be diabetic as well. And so I would, to me, it's a case of the liver biopsy, which would answer us the very clearly that whether or not there is a element of NASH, because while coming to the management, if the overlapping NASH is there, it's not just antiviral therapy which will help the patient. It would be whole then lifestyle modification and weight reduction regime importance comes down to manage the NASH as well, because hepatitis B may be causing, but the possibility of the NASH causing significant damage remains there. He's young, and we should look into that. And the question, starting the antiviral therapy, yes, even if it is NASH, I would like to start with antiviral therapy, because in any case, he is a cirrhotic patient. Though we don't have the current fibro scan, but we are not expecting it to be better than what it was 2 years back. So still, this patient have got significant fibrosis. He is a candidate of antiviral therapy. If there is overlapping NASH, that we would add on the NASH management protocol as well on him, with weight reduction, exercise, and carbohydrate reduction. And if possible, we can get, in my particular practice, what I have been seeing in the NASH, uh, though the data overall is not there, this is anecdotal personal practice, that I have getting very good result, and I've got few biopsy proven reversal of the NASH as well, with the pioglitazone and GLP-1 in non-diabetic patients even. And I've got quite 3 or 4 biopsy, paired biopsy with 6 months reversal of fibrosis even from F3 to F1. So and there are trials going on, and there's some encouraging data as well on this. But that comes to the specialized practice and control setting. But managing NASH would be an additional aspect of MRB. Starting antiviral, yes, I would like to start.
Thank you, Zeeshan. Uzair, if you can stop share here. And I would like to engage Dr. Nadeem Tehami. I hope he's still with us.
जी
Nadeem,
I'm enjoying जी
yeah, you're enjoying.
I'm
So
enjoying
we like to have
जी
your
जी
comments.
जी
My
मैंने
question to you is there anything on biopsy which will actually stop you on starting treatment? And of course, your general comments on this case also.
very interesting case and nicely presented. I don't think there's much left for me to contribute after Professor Altaf and Zeeshan. What I would like to know more about is the history of ischemic heart disease and other metabolic problems in the family, because as we all know, the main problem in patient with NAFL and NASH is a cardiovascular mortality rather than the liver disease-related mortality. So that's something I would like to know. One of the other things that you would want to find out in this case is if those risk factors were manipulated or not in the past, i.e., was patient seen by a hepatologist or a gastroenterologist or a general physician in the past, and if he was, and if he was advised, and if he was given some lifestyle modification advice, and if he did adhere to them, did those had any impact on his liver numbers, and as you were talking about, his lipid profile, HbA1c, so all those things. So there are patients, those who would present with NAFL, who may not have diabetes at a time, but we know at least 50% of them within the next 2 years will develop, as Zeeshan was already alluding to. So I think those things are very important to see the impact of manipulating the risk factors on the overall outcome of the liver disease. So if he has managed to improve his weight, improve his diet, and if that resulted in improvement in his ALT, so all those surrogate markers, then at least you know that the predominant problem here is driven by NAFL than viral hepatitis B. So that's just one aspect of looking at it. But when you add complexity to it and you say that this patient already has advanced fibrosis or cirrhosis, then I think it becomes a bit more academic whether you want to treat him or not treat him. I, to be honest, were inclined toward what Zeeshan was saying, that once he has developed cirrhosis, now there is a big question mark here if he has, because we are making that decision based on FibroScan. That was again few years ago, and we know FibroScan isn't the best test we have available. So yes, repeating it would help, and therefore comes the role of biopsy. So again, I think biopsy would certainly help you in at least confirming this, because if you have established that this man has got cirrhosis, then I think irrespective of what his HP surface antigen quantification is doing, his viral load is doing, I would be inclined to start him on the treatment, because you would then hopefully reduce his risk of progression and reduce his risk of developing hepatoma. One of the other things that you want to find out in this case is again his once you've established whether he has cirrhosis or not, then you would want to find out in degree of what sort of if he has portal hypertension or not. Because one thing that we tend to forget in patients when we are looking at patients with cirrhosis is whether they have portal hypertension or not, because the group which has portal hypertension is a group which then develops hepatic decompensation, compared to the group which has cirrhosis but does not have significant portal hypertension. So that would be maybe a step forward. In terms of biopsy, I think biopsy will certainly and will help you here. One, at least in establishing whether this man has cirrhosis or not. One. Two, at least it will tell you what is the predominant processes. Okay, I think as we talking about balloon degeneration, is whether it's a NAFL or NASH, or whether it's a predominant component of viral hepatitis. I think biopsy would certainly help. So my feeling would be yes, further investigation, as I think Professor Altaf and Zeeshan mentioned, to confirm whether he has cirrhosis or not cirrhosis. And I think biopsy is part of it. And once you have confirmed that he has cirrhosis, then I will have a very low threshold of starting antiviral in this case.
Thank you, Nadeem. Dr. Altaf, may I ask you, we have decided to start him on treatment, your preferred choice in this case, duration of treatment and on treatment follow-up?
For hepatitis B, I would certainly err in favor of tenofovir disoproxil fumarate. He's young, and there is no reason to start him on tenofovir alafenamide. I am among the two, entecavir and tenofovir. I like tenofovir more because of various reasons, more surface antigen loss in the long run. But remember, this is E antigen negative, so it's not going to happen. So my choice will be tenofovir disoproxil fumarate, 300 milligram daily. Treatment will be forever, lifelong. Cirrhotic. He's cirrhotic plus E antigen negative. Both these factors would dictate that he requires treatment lifelong. And as Nadeem said, you need to do an endoscopy to rule out varices, and HCC surveillance should be started as well. You have already done alpha fetoprotein, but you need to repeat ultrasound and alpha feto every 6 months for surveillance of HCC. So yes, tenofovir long-term / lifelong. Thank you.
Thank you. Zeeshan, इसके follow-up में we have decided कि we are going to lifelong treatment. हमारे पास दो पैरामीटर्स हैं, एक DNA viral load है और एक हमारे पास surface antigen quantity है. Do you fancy कि हम इसके follow-up में इनको use करेंगे कि और that will be immaterial?
जैसे कि अल्ताफ साहब ने बात की है कि in this particular case when the cirrhosis are already established, what has to be followed is HCC surveillance, and what Nadeem has been talking about, the portal hypertension, development of portal hypertension. Those would dictate the outcome and the complications what we are talking about. But following HBV DNA surface antigen is irrelevant here, because we are not going to change anything whatever levels we get. We get 4 HBV DNA negative. Are we going to stop it? Unlikely. Cirrhotic patient, we are not going to stop it. If we get negative surface antigen quantification less than 100 or less than 50, what are we going to stop it? No. So there is no point in following with HBV DNA in this particular case. Yes, what is important here is HCC surveillance and watch for the portal hypertension.
Thank you. Nadeem, a lot of doctors in primary care are listening to you. Can you elaborate more on
More on
this
this.
portal hypertension assessment?
Gee, portal hypertension. I think the problem here is that in general practice, and even in a secondary or tertiary care services, when we see a patient with systemic hypertension, we assess them, we start them on medications, and then we monitor them. Now, there comes portal hypertension in the world of hepatology, which is the most important aspect of a patient with a liver disease. Why? Because those who have, as I had said earlier, that you basically classify your group F1, F2, F3, fibrosis, and then finally say this patient has now cirrhosis. Now, those who have cirrhosis then should be classified into those who have portal hypertension and those who do not have portal hypertension. Why? Because those who have portal hypertension are the one who have a higher risk of developing hepatic decompensation. So how do we measure it? Do we have an objective way of measuring it? Unfortunately not. What do we have? We can probably just do this hepatic venous pressure gradient where somebody can, again, an invasive way of sort of somebody going into the hepatic vein, measuring pressure, and then going to the closer to the sinusoids and then measuring a pressure and then subtracting and giving us an assessment, which is an indirect assessment of the portal pressure and saying that this patient, this is the person's portal pressure. We do not do what we hopefully should be doing in the future. That is quite an invasive, but that is in endoscopic ultrasound guided pressure measurement of portal vein and then hepatic vein, and then actually subtracting those two to give us actual objective measurement of portal pressure. Now, I know it is a bit of a far-fetched and maybe one of my wishes, but as it stands, the reason I was mentioning all this because portal pressure is something really important that we should try to establish in our patients with cirrhosis. And how do we do it as things stand? As obviously, I think your colleague or nicely showed that you were looking at, so there's one way of looking by simply at their platelet count, by looking what the spleen size is. You can also look in ultrasound scan about the sort of, if you've got any obvious collaterals, what is the flow in the portal vein, which is normally sort of between 16 to 25, at least in our center. Some center has between 16 to 20. So if the flow in the portal vein is higher, so that's another way of sort of, so there are some ways of looking at the flow in the portal vein diameter, spleen size, patient's platelet count. Then you can maybe, the Bovino criteria, you can then decide whether you want to scope a patient or not, depending on the platelet count less than 150 and the fibroscan of more than 20 and going for endoscopy examination, looking for esophageal and gastric varices. So all these pointers would help you in establishing whether a person has clinically significant portal hypertension or not. And what is a clinical significant portal hypertension if they have presence of all these signs that we've discussed? And essentially what it means that this patient's portal pressure is at least more than 12. So that is probably a rough guide of measuring, of determining whether a person has clinically significant portal hypertension or not.
Asad, may I just make a comment? Thank you, Nadeem. Very well elaborated. Yes, it is extremely important to know whether your patient has clinically significant portal hypertension or not. हमारे जो जनरल प्रैक्टिशनर कोलीग्स हैं उनके लिए यहाँ पर मैं सिर्फ ये जरूर बताऊंगा जो नदीम ने बताया कि बवीनो 6 के मुताबिक अगर आपके प्लेटलेट्स लेस देन 150 हैं और फाइब्रोस्कैन पे किलो पास्कल वैल्यू मोर देन 20 है, तो ये वो पेशेंट्स हैं जिसकी एंडोस्कोपी जरूर कराएं. बाकी सिरोटिक्स को आप साइड पे रख दें, इनकी जरूर कराएं. अगर आपके पास 1 करोड़ पॉपुलेशन है क्रॉनिक लिवर डिजीज की, तो ये क्राइटेरिया आपको हेल्प कर सकता है इन जनरल प्रैक्टिस के किसकी एंडोस्कोपी करनी है और किसकी नहीं करनी. ऑफ कोर्स 1 करोड़ के आप एंडोस्कोपी नहीं कर सकेंगे, सो यू कैन यूज दिस क्राइटेरिया जो कि एविडेंस बेस्ड है और बवीनो 6 ने इसको रेकमेंड किया हुआ है. थैंक यू.
Thank you very much. Very nice discussion. We are open to questions. We still have about 5-10 minutes. अगर कोई burning question है from audience, regarding this case or any other topic on hepatology or GI. So fortunately, we have a galaxy of experts here. So anybody?
Can I just maybe re-emphasize the point of follow-up? चाहे आप उनको hepatoma surveillance कर रहे हैं या चाहे you're just following these patients up, most disease process tends to declare themselves when you follow a patient. So that is why I was mentioning earlier on that if you have a patient with NAFL and you've introduced or suggested all those just simple general lifestyle advice, and then you followed them up, and if patient has introduced those intervention in their lifestyle and it has had an impact on their liver blood test, on their blood pressure, on their cholesterol. So those are the things which would roughly guide you that whether the interventions that you've made or suggested have made a difference or not. And again, that would help you in defining what is the predominant underlying process of causing liver diseases. So a follow-up really helps. Now, I know it's probably difficult in circumstances like Pakistan because patient may not turn up or may decide to go and see another physician. And I think in that situation, I'm sure if you can encourage them to maintain some form of health record. So even if we can't maintain them, or if patient is able to maintain some form of health record, which they can carry on their mobile phone or otherwise, at least when they go and see another doctor, that at least they have got that record available to them, and therefore they can get a better consultation.
थैंक यू नदीम. और मैं प्रैक्टिस में सिर्फ अपना जो पॉइंट शेयर करना चाहूँगा. इन आवर फॉलो अप पेशेंट्स we have seen कि sometimes in a course of couple of years even subtle changes in alpha fetoprotein has raised the alarm for us. वो बहुत ज़्यादा नहीं होता, लेकिन अगर किसी का alpha fetoprotein 10 था और वो 15 से 25 पे चला गया, तो we just it just rings the bell, and we are looking more on excluding SCC. There is this question in chat: does it mean that in case of cirrhosis, viral load doesn't matter in deciding the antiviral therapy? Zeeshan has elaborated that. Zeeshan, आप एक बार दोबारा इस पे stress करेंगे?
Yes, exactly. When the patient is cirrhotic, when we are talking in context of hepatitis B, then the viral load or surface antigen quantification doesn't carry a meaning. Even with the recent guidelines in a negative HBV DNA patients, you can still start with the therapy, and the therapy remains lifelong. So the follow-up with the viral load or HBV DNA doesn't matter in established cirrhotic patients while treating hepatitis B.
And Dr. Altaf, एक question है, please explain the significance of surface antigen quantification.
Right. Surface antigen quantification, ये ordinary ELISA test नहीं है. This is done by two methods, Abbott के Architect और Roche के Alexis, इसको कहा जाता है. So ये हमें indirect evidence ये देता है कि viral replication क्या हो रही है. So अगर आप एक patient को देखें जो कि true, जिसको हम कहते थे hepatitis B E antigen negative patient या inactive carrier, अब उसको हम hepatitis E antigen negative infection कहते हैं, इनमें surface antigen quantitative बहुत low होता है, usually बल्कि always less than 1000. लेकिन अगर आपका पेशेंट इस जैसे ये डिस्कस किया सिरोटिक भी है, डीएनए कम है, लेकिन सरफेस एंटीजन बहुत ज्यादा है, ये ट्रू इनएक्टिव कैरियर नहीं है. सो ऐसे पेशेंट्स में एडिशनल इंफॉर्मेशन हेल्प करती है जो कि सरफेस एंटीजन क्वांटिटेटिव की होती है. दूसरी ये भी बताती है कि आपकी आउटलुक क्या होगी. सरफेस एंटीजन लेस देन 100 हो, आपने ट्रीटमेंट बंद किया, ये पेशेंट सरफेस एंटीजन नेगेटिव होने का चांस बहुत ज्यादा है, आइदर ऑन ट्रीटमेंट और विदाउट ट्रीटमेंट. ये बहुत हाई है, तो ये इंडिकेट कर रहा है कि हाईली रेप्लिकेटिव स्टेट है और वायरस की, ऑल्दो डीएनए चाहे लो हो लेकिन हाईली रेप्लिकेटिव स्टेट को शो करता है. सो इट गिव्स एडिशनल इंफॉर्मेशन डिजीज स्टेट में भी, प्रिडिक्शन में भी, अर्ली स्टॉपिंग रूल्स में भी. चाहे आप अगर आप इंटरफ्रॉन दे रहे हैं हेपेटाइटिस बी में और आपका पेशेंट ई एंटीजन नेगेटिव, पर्टिकुलरली डी जीनोटाइप में, आपको ये हेल्प करता है अलॉन्ग विद क्वांटिटेटिव कि आपने इलाज कब बंद करना है. सो ये या पेशेंट रिस्पॉन्ड नहीं कर रहा, अर्ली स्टॉपेज के रूल्स जो हैं वो अप्लाई कर सकते हैं बेस्ड ऑन दीज टू थिंग्स. सो इट इज अ गुड टूल. Of course, new markers are coming in. Hepatitis B core-related antigen and hepatitis B RNA. These are going to come and add to our armamentarium. लेकिन अभी surface antigen quantitative in certain situation is very helpful. Thank you.
Thank you. Dr. Zeeshan, there is this last question for you. If you can see in the chat, okay, if the patient is having parameters of CLD and upon evaluation, he is just hypertensive, no other parameters of metabolic syndrome or other causes of CLD have been excluded, can we label him as having NAFLD?
Again, the question of cirrhosis, clinically established cirrhosis with negative viral markers and workup for liver disease. मेटाबॉलिक सिंड्रोम लेवल नहीं होगा जब तक कि हाइपरटेंशन के साथ ओबेसिटी या डायबिटीज ना हो. दो चीजें चाहिए, डिस्लिपिडीमिया, हाइपरटेंशन, डायबिटीज और ओबेसिटी. ये चार में से कोई दो चीजें होती हैं तो that's the time when we label them metabolic syndrome. मेटाबॉलिक सिंड्रोम के साथ जो नैश या नेफिल्ड है वो एस्टैब्लिश होता है विद अल्ट्रासाउंड या एलएफटी डिरेंजमेंट हो तो उसको हम साथ में एसोसिएटेड कहते हैं, क्योंकि पैथोफिजियोलॉजी इस तरह से है कि दे आर एस्टैब्लिशिंग एंड डायग्नोसिस ऑफ नेफिल्ड सस्पिशन तो होती है अल्ट्रासाउंड के ऊपर, लेकिन डायग्नोसिस एस्टैब्लिश लिवर बायोप्सी MRBFF which is proven to be equivalent to the biopsy, but that is the facility which is not available in Pakistan. Short of MR-PDFF or MR spectrography, liver spectrography, liver elastography, we cannot predict fatty liver other than liver biopsy. So अगर liver disease है, cirrhosis established है, तो ये biopsy का केस है. इसमें हमें to evaluate the cause of liver disease में liver biopsy करनी होगी. जस्ट एक कमेंट, शॉर्ट कमेंट ऐड कर देता हूं. जो प्रीवियस क्वेश्चन सर ने बहुत बेहतर तरीके से एक्सप्लेन कर दिया है, मैं सिर्फ थोड़ा सा इसको और इसी केस के ऊपर ले जाते हैं. इफ दिस पेशेंट वुड नॉट हैव बीन सिरोटिक पेशेंट विद डीरेंज एलएफटीज एंड सरफेस एंटीजन, हाई सरफेस एंटीजन क्वांटिफिकेशन, लो वायरल लोड, तो ये जो एडिशनल इंफॉर्मेशन आती कि ये वायरल रिप्लिकेशन में है और ALT मोर देन ट्वाइस है, दैट कुड हैव बीन मेड ए केस ऑफ ट्रीटिंग दिस पेशेंट because this surface antigen quantification would have helped us कि ये वायरस रेप्लिकेट कर रहा है और जो है वो एक एडिशनल इंफॉर्मेशन हमें देता है. क्योंकि इस केस में ऑलरेडी सिरोसिस एस्टैब्लिश थी तो ये मैटर नहीं कर रहा था कि वायरल लोड क्या है या सरफेस एंटीजन क्वांटिफिकेशन क्या है. लेकिन अगर यहाँ पे सिरोसिस नहीं होती तो दिस वुड हैव डेफिनेटली प्लेड सम रोल इन मेकिंग ए डिसीजन फॉर ट्रीटिंग और नॉट ट्रीटिंग दिस पेशेंट.
Thank you, Zeeshan. It's about time. Kiran, it's over to you.
All right, thank you. Would like to thank our expert panel and spokes for participating, and also our chairman, Parsa Trust, Mr. Suhail Akhtar, our director, Dr. Asad Ali Chaudhary, Echo Payam lead, Dr. Amna, coordinator, Mr. Uzair and Haris in IT, and Salman for the support. Also, Pakistan Society of Hepatology and Feroson's Laboratories for their unrestricted educational grant. Good night, all of you, and over to you, Uzair.
Thank you very much, ma'am. Till next time, Allah Hafiz to all of you.